And I'd like to welcome everyone today to the 41st of these cardiac rehab and secondary prevention webinar series. The webinar series comes to you from a collaborative partnership between Rural Health West and the Heart Foundation, ACRA WA, and I'm just noticing it's being transcribed as well as recorded. Rheumatic Heart Disease in WA, and also we thank Rural Health West for receiving all your registrations and taking on quite a bulk of this partnership now. I'd like to start by acknowledging the Whadjuk people of the proud Noongar Nation on whose land I sit. I'd like to acknowledge all Aboriginal people in the room today. I'd like to pay my respects to Aboriginal people on all the lands where you sit. I work quite extensively in Aboriginal health, and I pay my respects to Aboriginal people's gentle spirits, their courage, their resilience, and their wisdom. And I thank them for the privilege of living on their land. I have with me today Rosie Walker and our presenter, Cate Mitchell from Diabetes WA. Just a tiny bit of housekeeping before we start is if I could just ask you to please put any questions or comments along the way in the chat. If you do have a question, please just come off mute and Cate will be happy to take your questions. We really appreciate you giving your time to learning about this really important subject today. So I'm going to pass to Rosie to introduce herself and Cate.
Thanks so much for that, Helen. Welcome everybody, and thank you so much for having us today. Like Helen said, taking your time out to listen to our very valuable messages. It's really important. So thank you. So as Helen said, my name is Rosie Walker, and we have Cate Mitchell here today. We're from Diabetes WA. Brief professional background. My background is in health science and health promotion, and Cate is a RN, RM, and one of our amazing credentialed diabetes educators as well. So today I'm just going to touch really briefly on Diabetes WA, what we do as an organisation, who we are, really quickly about the NDSS, and then Cate will take you away on a deep dive into cardiovascular disease and how that relates to diabetes. Okay, so prior to starting, Helen has already done an acknowledgement of country, but Diabetes WA, myself and Cate would like to acknowledge and recognise the Aboriginal and Torres Strait Islanders of the land in which we are sited today, and you are as well, and pay respect to Aboriginal elders past, present and emerging, and to any Aboriginal or Torres Strait Islander people who are participating today. Okay, we've already done some housekeeping. If you can please keep your microphone on mute, that would be fantastic. Until you want to ask a question, please jump in at any time with that, or you can write your questions in the chat box. This presentation will go for approximately 50 minutes, and then we'll have around 10 minutes at the end to explore any questions that you might have. Okay, so a lot of you are probably, I'm hoping, are already aware of Diabetes WA and who we are, what we do. Essentially, we are a not-for-profit organisation. We're there to support patients and anyone that's affected by diabetes, whether it's the patient, the carer, or their health professional that is caring for that person living with diabetes. our mission is to provide the essential support, the education and the services that allow people affected by diabetes to live a really full and healthy life. And we do that in a number of ways. Of course, all of our strategies, our goals are based on evidence-based solutions. We want to prevent, help diagnose, help self-manage, and we just offer a really, really great support wraparound service. All right, so I'm sure I'm preaching to the converted already. The National Diabetes Services Scheme is something I just, would have to touch on. It's, of course, the structure of the NDSS is, people should be registered with the NDSS upon diagnosis of diabetes, whether that's gestational type 1 or type 2, and this is best practice to be done automatically. A lot of people associate the NDSS with, getting their subsidised or free, insulin needles or blood glucose testing strips through their community access pharmacy. But some people aren't aware of the structure in that the NDSS is Commonwealth funded, and then the NDSS fund the programs and services that Diabetes WA run. So, by someone being registered, it gives them, this opportunity to, have all these amazing services offered to them for free. So hopefully that's already something that you guys are doing as an automatic thing. All right, so some of the programs that we offer, you've run both face-to-face as well as virtually. We've got the Desmond program, as you can see at the top there. That's an acronym for Diabetes Education and Self-Management for Ongoing and Newly Diagnosed. This obviously lays a really solid foundation of understanding. We want people self-managing. That's ultimately what we really, really want. As much as we want to be there to support patients, and you as health professionals are as well, we can't be there every second to hold people's hands. So once they've got the skills and understanding, the education and that sense of empowerment of, yep, I know what I'm doing here, based around their dietary intake, their physical activity, monitoring their blood glucose levels, all of these, these things that they need to be able to do themselves. These courses really lay that foundation for them. So, like I said, they run face-to-face, multiple different suburbs. They run metro as well as regional. But if people aren't comfortable participating face-to-face, then there is online virtual sessions as well. Then we have a suite of SMART programs, which are topic specific around, as you can see there, carb smart, ready, set, go, let's move. Obviously various different topics that are covered. Again, they're more sort of 2 or 3 hours, run face to face as well as virtually. That workshop calendar I can forward on to Helen, and perhaps she can forward that on to you as well, and then you can have a look for yourself. And there's a QR code there if you want to get your phone out, and that will take you to the booking the screen there. Okay, as far as other services and programs are concerned, we have a range of different programs that are available online. And again, you can scan the QR code if you really want to. They're, I guess, designed to top up people's knowledge. It's a platform where they can go, where it's credible information. They've still got that support without participating in an all day or a 2 or 3 hour session. They can track their dietary intake, their physical activity, and like I said, it's a good place for them to go, where the information it's factual. It's like we get so many people turning to the internet, and it's so confusing for a lot of people. There's misinformation out there. People turn to Facebook or TikTok or all these different platforms where they're getting misinformation. So we want people going to a platform where they get the right information and support. Okay, so mindful of time, I won't go on about all the programs and services we have. This is kind of just giving you a bit of a taste. If you want some resources, sort of like specific, topic-specific resources, then the NDSS, you're probably already using these fact sheets. They're amazing. They're available in different languages as well, and you can download them. Use that QR code, or you can get in touch with myself or Cate, and we can forward you on those resources as well. For those that are working out of the regions, this is a really good service for you guys to keep in mind. We do have a telehealth service. It's been operating since 2015, available in 7 different regions, including Aboriginal communities. This it's a consult via VC. It's really, really valuable. We know the access in regional areas can be limited, or often is limited, and for somebody to be able to speak to someone like Cate, who's one of our diabetes educators, and our multidisciplinary team as well. We have GDM specialised support. We do have an endocrinologist that comes in as well once a month, and it's just a really, really valuable service when there's limited services available in regional and remote areas. So something to keep in mind there as well. And for metro areas, we do also have, or not even just metro areas, you can give us a call anytime, Monday to Friday, 8:30 to 4:30 on our helpline, and this gets you through to one of our CDEs as well. So if you forget everything I say today, just remember we've got that. Okay. Like I said, I just whipped through really quickly, gave you a really brief overview of who we are, what we do, and a few of our services. And now I'll hand you over to Cate, who's going to talk about cardiovascular disease and how it relates directly to diabetes. Thank you, Cate.
Oh, thank you. Hello, welcome. Thanks for joining me, everybody. Hopefully I've taken over the screens appropriately and you can actually see everything that I'm about to talk to you about now. So my brief was to try and present some information about linking diabetes and cardiovascular disease. So I've decided to try and share with you just these 4 components, bearing in mind I could talk to you about this all day and you would listen to me because I love it. I'm passionate about it, but I will try to contain myself and just do that link, do the numbers with you, look at reducing the risk in diabetes management, those practical skills, what we can do, and some latest developments in research that can be a little bit exciting and can open up some eyes and some thoughts for you all along the way. Just got to get my mouse moving. So first of all, let me just, sorry. You can't teach an old dog new tricks, can you? So first of all, I'll go through that link between diabetes and cardiovascular disease. So researchers are still looking into how the damage is caused to blood vessels and how it occurs in diabetes. But the evidence suggests that the higher than normal blood glucose levels cause this state of chronic low-level inflammation in the blood vessels. And it's this factor that is increasing the risk of cardiovascular disease. The way I try to explain it to everybody in lay terms is that glucose molecule, that great big molecule, does some damage, bumping around, crashing around, creating traffic accidents, traffic jams, damaging the sides of the roads, creating potholes, and we don't always have the infrastructure to go in and clean those roads back out again without some pretty invasive medical science. So that glucose molecule is doing that inflammation and causing those problems. During pre-diabetes, the presence of these various inflammatory cytokines and oxidative stress will lead to the pathogenesis of type 2 diabetes. So that's all linked. So we can't say that you might have a little bit of diabetes, or if you don't sort things out, you'll get diabetes, because it's happening. We're already creating that inflammation process. So pre-diabetes is just as significant a diagnosis as type 2, which is, as you know, health professionals, why we have to fight and advocate for prevention as our first line. But as we know, prevention's not as sexy as curing, so we have to keep working on that. Furthermore, we know that insulin resistance and that chronic hyperglycemia will lead to micro and macrovascular complications. So the cardiovascular disease, heart failure, hypertension, chronic kidney disease, and atherosclerosis. And in our diabetes land, we know these as the retinopathy affecting the eyes of the little blood vessels, the neuropathy affecting the kidneys, and the peripheral neuropathies. And anybody that's lived with any kind of neuropathies will tell you that once you have damage to those nerve pathways, you might as well call it quits, because there's no motivation after that. It's incredibly debilitating. And then, of course, we're looking at that heart with the coronary artery disease as well. So diabetes is linked in because it's affecting the pump and it's affecting the pipes. And that's the bottom line for it. Change mouse. So the stats, the numbers, for those of you that really like those numbers and you're good at it, I'm not so great at it. I find it really confusing and a little bit baffling, but I'll throw them at you just for fun. So 1 in 20 Australians have diabetes, 1.3 million people in Australia. It affects men and women at the same rates. It's pretty significant, but we know that generally type 2 diabetes is recognised earlier in men, potentially because they're carrying that excess weight around their middle, which is a predisposing factor of diabetes. But ladies being ladies like to catch up, and when we go through menopause, we'll start putting our fat layers on around the middle, and we'll catch up and we'll be equal to you by the time we get there. So no advantages to us in the long term. The most common type of diabetes obviously is type 2 with 85.5%, and yet type 1 is the one we seem to know the most about, or certainly are more familiar with, knowing that they have certain regimes and we can follow those regimes. And type 2 tends to be the one that creates all of the dissension and all of the myths and all of the misrepresentation, and that you did it to yourself, if you'd have done things better, if you'd eaten better, if you'd moved more, all these factors about how we could have prevented it, when in actual fact we know there's a lot of influences around type 2, and I bet you anything in 10 years' time, and if I did this presentation again, we'd have more. There'd be different factors. We know that family history and ancestry play a part of it. We have no say over whether many generations ago our ancestors lined up for good looks and charms and ignored locks and keys, which is, insulin and insulin resistance. So basically, there's predisposition. We know we have no cure for aging. If anybody out there's got one, I'd like you to share it with me, but that's going to have an impact on our rusty old locks as well. Oh, Helen wants a share of that as well. So we know there are some factors that we simply have no choice over it. If it was so streamlined that we could say that all overweight people would get diabetes, then we could maybe be a little bit more consistent, but not all overweight people do. Not all skinny people don't. So it's a very contentious disorder to have with, because of the myth and the shame and all of the other emotional components to it. The rate of diabetes increases with age. So I just mentioned that age is obviously that contributing factor. And in 2020, diabetes was ranked 7th as the leading causes of death in Australia, with 5,148 deaths. And we know the statistics are showing us as we go through each one of those ABS profiles that number is increasing, and that isn't even linking in the hospitalisations with it. So quite a significant burden and an impact on our community, those numbers. So then we'll have a look at, did I get that to go? No, I did not. The numbers relating to the link between diabetes and cardiovascular. So an estimated 1.2 million Australians aged 18 and over, which is about 6.2%, had one or more conditions relating to the heart or stroke or vascular disease. So that's quite a lot of people with cardiovascular disease, and so a huge burden. The rate of heart attack, stroke and vascular disease was higher among men at about 6.5 than women at about 4.8, and that's age standardised. Potentially, again, because of the different metabolic aspects relating to the difference between men and women, but 6.5 and 4.8 is not a great deal different. The rate of heart, stroke and vascular disease amongst Indigenous adults was more than twice that of the non-Indigenous population, and that's horrifying and very, very distressing. Like Helen, I just feel like with those kind of numbers, where's the bridging of the gap? That's significant for me. And that's not actually including renal disease. If we added in renal disease, we're not talking twice, we're talking 4 times the burden. Similarly, the rate of heart, stroke and vascular disease increased with the person's age again. So obviously all those body parts are wearing down at the same rate as our outsides are, the insides are too. Heart, stroke and vascular disease was reported as a comorbidity by 32% of people with kidney disease. So that is that two-way flow. If you've got kidney disease, you've probably got cardiac disease. If you've got cardiac disease, you've probably got kidney disease, and vice versa. 22% of people with diabetes also were linked in with that heart, stroke and vascular disease, and 20% of people with a chronic obstructive pulmonary disease, and 19% of people with cancer. So that's that link of cardiovascular to all of those other comorbidities. So they're all going to be a primary health focus. We can't ignore any of them. And because they're all going to have that impact on each and every one of us along the way. So let's start to jump into how do we reduce the risk? What are we looking at? How do we make it better? How do we improve the outcomes for people living with diabetes? And subsequently, how do we improve those outcomes for people living with cardiovascular disease? The bottom line is we've got to look after the pump, we've got to look after the pipes. That's it. So the pump, our blood pressure. If we put thick and sticky stuff in there and lots of it doing bumping and grinding away there, then the pump is going to have to work harder. And that pump is going to go under pressure and we're going to have some problems. So your heart attacks and your infarctions. So the guidelines for people living with diabetes is to have their blood pressure 130/80. Now, you might think that that number is different because till very, very recently, the number was 140/90. But we've lowered the benchmark for reducing the risk to 130/80 for those with those comorbidities. So higher blood pressure and glucose are not a good combination together. That heart is just working way too hard. So it requires us to use all of the same principles that you've probably heard to death, and I'll try not to bore you too much with them. It is about eating healthy and managing weight and getting physical activity, the new smoking. We've got to try and lower that blood pressure. They're the keys, those modifiables that we can do every day and encourage and motivate the people in our care and who we're advocating for to meet those goals as well. But however, blood pressure is such a vital component. Medical management must be considered, and anything you can do to encourage and promote individuals to accept and to take blood pressure is probably our leading success. We know that improving blood pressure improves the outcomes significantly. So that's a primary goal of getting that blood pressure at that target of 130/80 if they're living with the two. I'm just going to pop this in there. It's not going to be anything you haven't seen or are aware of, but just in case, or for anybody that's still intrigued to do some more research, all of our guidelines that come from the RACGP, including that hypertension risk for blood pressure. I've popped those links in there, and you can also take a photocopy of them and then click on those links later on. And they will actually look at your cardiovascular risk and your pathways for medical management of blood pressure. Start with this steps, next to this step, next to this step, and it's clear and concise, and we'll follow those guidelines. And it's all consistent across all health fields. We use those guidelines to improve risk with blood pressure. Our next target is cholesterols. I believe that some of you may have included in a talk about cholesterol just recently. Again, those targets are significantly reduced for people living with diabetes. Again, glucose creating those opportune moments for fats to overtake, those lousy old LDLs to get stuck in potholes and created with the inflammatory process. So our guidelines here are the LDLs less than 2. You'll see on pathology results that it'll say much higher profiles in the norm, but if you're living with diabetes, the LDL target becomes much lower, of less than 2. And even lower than that, 1.8 if you already have a cardiovascular disease pathogenesis. HDLs, we want them more than 1. Triglycerides, we want them less than 2, and the total cholesterol is less than 4. So pretty tough targets. I'd have to go as far as to say almost impossible targets for somebody living with a metabolic condition. So again, we're going to have to look at medical management to support the same baseline ones of healthy eating, fibre, fruit and veg, physical activity, weight management. But because those targets are so strict and no margin for error, medical management is going to be needed to be included. The combination of high blood pressure, high glucose, and high cholesterol is the trifecta, but we're not winning very much with it. It's a pretty poor outcome. So that's why those risks are, targets are so significant. And of course, I've used all of these through that RACGP guidelines so that we're all on the same page. It becomes very hard in health when everybody's playing from a different playfield or a different map. So we're trying to keep it really consistent. In terms of glucose management, we're trying to maintain our fasting levels between 4 and 7. A little bit tighter in type 1, a little bit 4 to 6, but fasting 4 to 7. Postprandial 2 hours, we want that to be less than 10. And remembering that when we're talking and educating people, postprandial is 2 hours from the first mouthful. Our glucose metabolism starts the minute we look at food. We want that pancreas wound up and turned on and no longer have that computer whirring by 2 hours. So we're checking at 2 hours to make sure that pancreas has actually turned on and started doing its work. And if it hasn't, that's when we start to look at interventions to try and make that pancreas turn on a little bit quicker, get active a little bit quicker, and help it with its job. So all of our therapies are around making the pancreas work better, work quicker, or have somebody help working along if we're doing injectables like insulin. The pre and post spike, we use a guide of about 2 to 3. So if you know what you are before and you don't, and your food has taken you 2 or 3 millimoles higher, that's good. That's consistent. That's a really easy way for somebody to know, is this food okay for me? And that right there is a diabetes diet. There's no such thing as you can't eat this and you can't have that and you can do this. It is literally, where does food take me? It takes me 2 or 3 millimoles. Well, that's fuel. I can run my car. If it's more than 3 millimoles, pancreas is working really hard. It wasn't great in the first place, a bit dodgy, key's not working. It's now going to get really tired real quick. So that is too much food, too much carbohydrate, or maybe just a poor quality carbohydrate. And that becomes our diabetes management. Every single person, if they know where food takes them, can make their own clinical learned decisions on what to do about that food. They may choose not to do anything at all, or they may choose to reduce or burn it off another way, which becomes our next component of diabetes management. So these are what we're going to do. This is how we're going to try and help somebody to lower the risk. The quit smoking, we really don't want to have hard arteries and loss of electricity and all the damage done inside of a blood vessel on top of what's happening with cholesterol and what's happening with glucose and what's happening with blood pressure. So quit smoking, first line. We've got to try everything in our repertoire to promote quitting smoking. The keeping active, I mentioned that's the new smoking for our generation. The lack of movement and the lack of significant movement that makes us huff and puff is having an enormous impact on our pipes and our pump, so our heart and our blood vessels. We need to try and meet those Australian guidelines for physical activity of about 30 minutes every day, broken down into 10-minute chunks of manageable exercise, but it's got to be huffy and puffy. We have got to make the heart start to speed up so that it can recognise that we can move glucose without insulin, so that we can move away glucose out of the way, we can move the cholesterol out of the way, we can undo the damage that maybe some poorer health lifestyle choices have created. So it's not doom and gloom. It's just unfortunate that physical activity is the one that we like least to start. It's kind of like the end of the bucket of care. But if we can find ways to encourage and promote physical activity to be right at the bottom of the bucket of care so that the other ones don't get piled in on top, that would be great. The eating healthy, the balanced meal, the balanced diet, I'll go through a little bit of that in a minute, but it's nothing new. It'll be preaching to the converted. Limiting alcohol, and those guidelines have changed, as you know, so that's including some alcohol-free days, and ladies are now allowed to drink the same amount of alcohol. Woohoo! Oh, sorry, that was out loud. Aiming to support getting those clinical targets, the cholesterol, blood pressures and blood glucose levels, managing our weight and waist circumference as those clinical markers that can predispose somebody to type 2 diabetes. So managing weight and waist circumference becomes part of it, but it's a very complicated process with weight. As you know, it's not as simple as less in, more out, and you lose weight. It just doesn't work like that, but certainly more in and less activity, it goes on at almost twice the rate. So it's very complicated and it's going to need support and advocacy to achieve those goals. We've then, sorry, I've just linked you in here with the diabetes management, also from the RACGP, but that includes the clinical treatment plans and chronic condition plans, and also includes that bucket of care treatment. So I mentioned the eating, the exercise and the weight management as our first line of the bucket. The second line of the bucket is metformin or a glycoside, and in some cases insulin. And then we start layering on therapy. So what's the least invasive and the easiest for people to start with? And then we move into the bucket of care to try and recognise when something needs to be added to make sure we're meeting our goals, our blood glucose goals. Sorry, I think I forgot to mention it back at the HbA1c, that the 3 monthly tests where we can actually check to see how much glucose is attached. Our guideline for that is less than 7%, but it should be individualised. 7% is not always appropriate for an older person, and it's not always appropriate for somebody newly diagnosed. We try to keep our goalposts achievable, and we'll move that guideline to the best, but standardised, it's below 7%. And there's a really good reason why the glucose molecule is called an A1, because it's our primary fuel source, so we've got to take care of it. Second line therapies, obviously, is if we're not getting those HbA1c targets or blood glucose targets. Those will include the SGLT2s, the DPP4s, the GLPs, and then sometimes sulfonylureas if you haven't already started in first line, and potentially insulin. And I'll go through that a little bit more as we go through these, but it's, again, those standard NDSS guidelines and the RACGP algorithm for glycemic management that you should all be able to access easily. So medication therapy, how do we work out and where do we decide we'll go with medication therapy? So first of all, if they're on the first line of therapy and they're not taking it, it's probably not much point to escalating it. So it would be a good place to start to find out why, what the potential problem is. I can hands down first up say that one of the first things that's stopping people taking metformin is the size of it. It's massive and it's really hard. It can't be broken. It's, you know, all of these it's got to be had with food. It's such a complex one that it's going to make it really hard for some people to be compliant with. But looking at it, that escalation is, you know, are we at a HbA target, A1c target? What is the target? Has it been individualised? Do we need to escalate? What other contributing factors are making it so that they have high blood glucose levels? So are these things transient or less permanent? So things that are affecting blood glucose levels in the short term and not the long term. So things like having undergone an illness, a recent illness, steroid injections, which we know cause insulin resistance for a short period of time, antipsychotic medication that can cause high blood glucose levels, the thiazide diuretics that can cause higher blood glucose levels. So look, actually identifying if the blood glucose levels are high in a short-term period or a long-term period, and then obviously looking at escalation if this is long-term. Immunosuppressants like cyclosporin have been known to have an impact on them. So medication is really important to look at them. Have we even looked at the modifiables first? Is the individual going to be able to do the modifiables? Should we refocus and re-educate and re-support and re-advocate for those lifestyle choices, and build up from there about whether or not we escalate down those ones? So I've included this little bit here just because I find it a little bit of interest for people. So the UK did this huge prospective study on diabetes to have a look at whether or not the management of diabetes is going to improve the outcomes for people in the cardiovascular world. Nearly 5,000 participants included in over 10 years. We noticed that intense glucose control did improve the microvascular morbidity, but not necessarily mortality. Insulin and sulfonylurea were both similarly effective, so the one or the other, but at least one of them was had the positive outcomes in terms of microvascular morbidity. Metformin was more advantageous for those with obesity as a comorbidity. I'm sorry for those that still don't consider obesity as a chronic condition. However, metformin tended to be slightly less likely for people to gain weight, or in fact could lose some weight because of that impact on the gastric symptoms and people feeling fuller for longer and tending to not eat quite so much. It does plateau out a little bit though after being on it for a short period of time. And then the intensive blood pressure control was deemed more beneficial, improving both outcomes of micro and macrovascular morbidity and mortality. So I hark back to that beginning where we have to look at blood pressure as our first line target as well to improve both macro and micro. There are other studies. There is an advanced study, an ACCORD study, and a VADT study that have all tried to show the benefits of glucose management for cardiovascular benefits. For any of you that love to go out there and look at research, that might be worth following up for yourselves. I link you into the rosiglitazone disaster. This is a diabetes medication that was released to improve blood glucose levels. However, it was found to cause or worsen heart failure. It increased LDLs in our total cholesterols. And up until 2008, all trials for new glucose medication only had to show that they had an effect on blood glucose levels, and our job was done. Since this rosiglitazone disaster, we now know that from 2008, we need to have all new glucose-lowering medications to undergo large cardiovascular outcome trials as well. So we've got to try and look at both of them. So we learn some lessons along the way. Sometimes they're quite valuable and quite painful. And here's where I get a little bit out of my comfort zone.
Okay, I was just about to say you made up for it with the SGLT2 inhibitors. We did. We had a huge comeback, didn't we? I'm not going. I'm sorry. It's out of. I don't do all the fine statistic numbers. That's just so outside of my scope or my brain power. Because when something important like that goes in, something really important has to fall out for me. There were lots of trials done for the different types of SGLT2s. These are the medications that end in flows, and for those of you that don't like to try and remember which drug does what. So if it ends in a flosin, sounds like something that like an antibiotic, it's an SGLT2, which means what it's doing is pumping out that sugar out of the bloodstream through the kidneys and out into our wee, so we're getting rid of it. There was lots of tests, the dapagliflozin effect on cardiovascular, the DECLARE, the canagliflozin cardiovascular assessment study, CANVAS, the empagliflozin cardiovascular outcome trials in type 2, blah, blah, blah. But as you can see, without going on and boring you any more than that, where are the numbers? All getting better in terms of heart failure, hospitalizations, cardiovascular disease, and obviously the MACE outputs as well. So it's all looking a lot better. So we're avoiding those major adverse cardiovascular
vascular effects. So this is what we're that we wanted, and even more research has come into play where we can actually start to implement second line therapy with SGLT2s with a far lower eGFR, so less renal output as well. So those numbers came down. Once upon a time we couldn't start them on individuals that had some evidence of renals. Now we can even start them with people with some evidence of renal. So that is fabulous news, agreed. So let's give you the pros and cons of the SGLT2. I would almost hesitantly put the cons in a shaded version because the pros are so good. It's been known to reduce the HbA1c by 0 to 1%. And again, sorry, skipped a little step back in the blood glucose. We know that for every 1% higher of your HbA1c, you get about 30% extra poor outcomes on cardiovascular disease. So if we work the other way, we're going to prevent cardiovascular disease and adverse cardiac cardiomyopathies. So improving by 0.5 to 1% has been known to have a little bit of weight loss, but it's fairly weight neutral. It has been known to help with blood pressure. Obviously, helps with those MACE outputs, those adverse cardiac effects, reduced heart failure hospitalizations, very renoprotective, which is why we can now use it on those lower eGFRs. The cons were the UTIs, the gastric upsets, increased urination. So people were complaining that they were having to get up in the night, which is quite intriguing because those with high blood glucose levels were also getting up in the night to pee. So how would you know? But they do have to pee a little bit more. Some volume depletion, obviously, and we can have that associated electrolyte imbalances for people that may potentially be a little bit dehydrated by not volume replacing. Dyslipidemia has been noticed with some of them. Hyperglycemia with or without the when you're taking it with the sulfonylurea insulin, sorry. Perineal necrotizing fasciitis, which nobody would want, so that would be a real good deal breaker. There's been some small link to some fractures and amputations, and then the biggie, the euglycemic ketoacidosis, if the individual is unwell on an SGLT2. So really important when they're unwell that they have a really good sick day management plan if they're on an SGLT2. So those frozen ones. So then we've got the next biggie, the one that's exciting, and we were all super excited, and it was working so great, and clients were coming off insulin and things were doing fantastic, and then we couldn't get it, is the GLP receptors. So those are the ones that are injectables, once a week injectables for long acting or once a day for short acting. And they worked by decreasing appetite and increasing that sensation of fullness. So instead of feeling like you were so full you had to undo your pants on the drive home from the dinner, you are now getting that sensation while you're sitting at the table. So that was a real game changer in terms of what's happening. Thinking about it logically, when you have a metabolic disorder where the primary fuel source is not getting through to the engine of the car, it is going to demand feed me, feed me, feed me. The cravings would be unbelievably overwhelming. So nothing to do with willpower, pure survival. These individuals are trying to get glucose no matter what way. And then we give them a medication that stops them feeling like they need glucose. It's a game changer. Obviously, the impacts on the heart was lowering blood pressure, increasing the heart output, decreasing myocardial contractibility, and then that cardioprotective outcomes with the GLP. I've already mentioned that it was renoprotective. It allows the kidneys to regenerate, increases the sensitivity at the muscle or cellular level of taking up glucagon, and it also reduced adipose tissue, so that significant weight loss, reduced hepatic glucose production, and the biggie, increased insulin sensitivities, decreased glycogen secretion, and increased insulin biosynthesis. So we know it as a weight loss drug, but we're out there in TikTok land. But here in diabetes, we know it as the little beautiful bubble wrap around pancreas. And the pros and cons around that one. Oh, sorry, I'll just show you that. So again, all the trials, all heading in the right direction. Everything's working way better than in the cardiovascular on all of those studies that were done. So basically, everything getting better. Remembering that some of those GLPs got removed from the market for want of lots of different reasons. So we're now looking at things like using brand names, the Sixtender once a day. You can still get Byetta twice a day. You can get the long-acting Trulicity and Ozempic. Maybe coming, maybe. Pros and cons. So this one reduces the HbA1c by 1 to 2%, so double the SGLT2. And then you've got, the benefits were similar to basal insulin in reducing HbA1c. So without the risk of hypos. So, the same benefits of HbA1c as a basal insulin, without all the other side effects to it. The cardiovascular benefits for patients at high risk, and the renoprotective benefits, and then of course the massive weight loss of about 8 to 10%, depending on which brand. I think Trulicity was 5 to 8, Ozempic was 7 to 10% body weight loss. The cons were that it needed to be injected, but it sure as eggs wasn't a big enough con for people in weight loss not to take it up. So I can't imagine why it would be such a significant one in diabetes, because not even cost had an impact in weight loss. So there you go. It's not really a con, is it? The gastrointestinal side effects were probably the bigger one. It did tend to make people feel very, very nauseous, and I've had clients that have been nauseous on it for right up for 12 months. So you can imagine their disappointment when they could no longer get it, and the thought of having to start again is too much for them, because they feel like they're going to have to do another 12 months of trying to get their body used to having that really horrible gastric symptoms. It needs to be used in caution with a history of pancreatitis, because that can be one of the side effects, or problems with gallbladder. And then there was that funny little T-cell thyroid that indicates to people they shouldn't have it. Semaglutide had a small link to a diabetic retinopathy, but I think that was pretty rare. So there is your diagram, prettied up for you to explain the difference and how we're getting those benefits of reducing those poorer outcomes for them. So obviously you can see how it helps us with the different types of medications there. So whether we're going the GLP or the SGLT2, which you can see there reduces insulin resistance, reduces hyperglycemia, reduces the hyperlipidemia, and reduces the cardiovascular disease. So both of them, winner, chicken dinner. So remembering the SGLTs are working on the pump, making the pump work better, and the GLPs working on the pipes, making the pipes clearer. So the combination is really good. Obviously, if you're on a GLP, you don't need to be on a DPP-4, kind of looking at both at the same pathways. The DPP is working on the incretin hormones, again, turning on that pancreas, getting the pancreas working. And those ones have got those on the fence kind of benefits, with or without some changes to lipids, with or without some changes, a little bit static with the cardiovascular. But without, it's all red, it's all downhill. So without any of those therapies, increased insulin resistance, increased hyperglycemia, increased hyperlipidemia, and increased cardiovascular risk. So a good option for our escalation.
Just a comment
from
deep in about supply being patchy for the Byetta.
Well, so they're all really patchy. At the moment, I think Byetta is probably the safest bet, but it's not subsidised. They're paying a lot for it in type 2. And it's, again, of course, it's not as convenient as the once a day or the once a week. Ozempic is sneaking back into the market as we speak, and it's being prescribed in high risk. We're keeping the supplies for those that need it the most. Most of the regional areas, pharmacies and medicos have been diagnosing it and prescribing it to those with renal problems, because once you're on dialysis, what medication you can have is almost nil. So, but we can use a GLP. So they're the only medications that are working and we can still use for people in dialysis with all those end-stage renal diseases. So at the moment, I think it's just being used in those populations for those really high-risk renal patients. But I would imagine that if you had a GP had a high-risk cardiovascular or cardiac patient, it would also be prescribed. And then it'll trickle down as the supply gets better. My understanding is that it's getting better and better, and it should be a pretty secure supply of Ozempic. I haven't heard anything about Trulicity before long, where we can start getting those cardiac benefits by putting them back onto a GLP. So it's coming, Helen, but we just don't know when those supplies will be good. We do know that there's been a whole factory built in the US, and the US are going to supply themselves, so there's going to be way less strain on it. And we also know that the Australian government has approved Wegovy, same drug but for weight loss. And Wegovy, I really feel it in my bones, is going to start getting released very soon. I've started to see some ads on TV that are intimating to me that big things are going to happen in weight loss. So I genuinely believe Wegovy will release on their market, and that is going to secure up those Ozempic ones. So you can say you heard it from me first. I get no money from this. I'm not endorsed in any way. You probably all had a little chance to look at that. So everything I've just said then, the bucket of care, weight loss, healthy eating, exercise, metformin, and then we're moving down to whether we're not using the SGLT2s, those flozins or insulins, the GLPs, and then other patients without those needing to have a more standardized HbA1c can have any one of them, the sulfonylureas, the GLP, the DPP4 inhibitors, and the SGLT2s. So all of those medications for clients that aren't with those higher risk of heart and renal. All right, the exciting new stuff. How am I going for time? Or a little bit. I've got a couple more minutes, maybe. So some stuff that we've that's out there that's potentially coming up is there's been some talk about an oral semaglutide, so similar to Ozempic Trulicity, but in an oral. It's at the moment it's a bizarre thing where you have to take it with half a glass of water and no more. It has to be on an empty stomach and nothing in it, and it needs to have nothing in it for a long time. It has to be half an hour before you eat anything else, and if you put anything after it, it doesn't work, and you've got to stand on your head, stick your tongue out, and 10 times for it to work. But the good news about it is you've got to we found a way to put it in the stomach and use it effectively. So that's exciting, because if they can do that, even if we do have to stand on our head and kick our feet 10 times, they've managed to find out how we can put that molecule in the stomach and have it being absorbed. So how much further must we be away from an oral insulin? That's where my head goes. How far away? If we can come up with a way to inject a long-acting semaglutide that can go into the body once a week and stay in our body and break down slowly, how far away from a weekly insulin? These are the exciting parts, the new developments. They've got to be coming. We wouldn't be looking at a long one-weekly GLP without really looking at what we can do about insulins. Are really super long, and we have to have got better than that, because we've already got the ultra long with Toujeo. So these are the exciting new perspectives that we've got. Then we've got the tirzepatide, the new medication that's looking at a combination of the GLP and a GIP. The exciting thing about the tirzepatide has been that the GLP looks at 5 to 10% body weight. The combination has looking at 25% body weight loss. So very comparative to bariatric surgery without having invasive surgery. So this is wow stuff. I don't know how far away we are, but jeepers creepers, that's got to be money, because if the GLP made that much money, imagine what the combo will do. So that's a huge one. So that's the exciting stuff coming up along the way. We've got some big changes even in type world land where there's some information that if we can get them at stage 2 before diagnosis of type 1 in that immune pathway where the body's developing those antibodies, we can actually prevent type 1. And then obviously the newer research about changes in management of type 1 with closed loop, getting closer and closer to having that external pancreas. And then ultimately the look at the cure of regenerating beta cells. There's some medication trials going on there about how do we regenerate beta cells. So that's going to flow through and trickle through to type 2 land as well, because we know that when a beta cell gives up because it's tired and exhausted, it's gone for good. And we know when it's attacked by our own body, as in the autoimmune type 1, it's gone for good. So knowing how we can regenerate is next on the cards. And then hopefully I'm out of a job. Question time.
Oh, wow, that's been a fabulous presentation. I feel there's a number of questions out there, and please come off mute and ask. For me, the prevention message of the high blood pressure, it damages every cell in the body, and it's every organ affected, and yeah, that's huge. Your message around self-management, your message around, making sure the patient, what matters to them, all that is so important. And pumps and pipes sounds like it's a new dance club or something. Fantastic, really great. I think I'm going to put Deep on the spot and ask if he's got a question there. I'm just wondering if you're from WA or Eastern States, Deep.
No, I'm from Bunbury.
Oh,
Helen.
Bunbury. Cool.
Yeah, you probably don't remember me.
Oh, I do.
I was at, yes.
I do. Deep was in the ambassador program. Beautiful.
That's right. Yes,
Yep.
I was there a couple of years ago. Now the question I have is regarding GLP-1. Is that do we really have, because in my practice, I've seen a few patients because of the availability issues when they stopped it, I guess people with type 2, because weight loss was really pronounced, but what they noticed that they regained that lost weight very quickly.
Yeah, Deep, what I noticed with my clients and everyone else, it's not obviously scientific, it's anecdotal, is that once they stopped or couldn't get that GLP, their appetite, their cravings, their response to carbohydrates came back like raging bulls.
Yes,
And it
that's
was
exact feedback I had.
incredibly,
Yes.
yeah. And then, of course, because their glucose levels were so incredibly high, they got popped onto insulins when they hadn't been on them. So, imagine the psyche behind now finding out that your diabetes needed insulin, and then or escalating insulin. And then, of course, they were popped onto these low dose insulins because they've never had it before. They're insulin naive, or were trying to reintroduce insulins, and then it just stayed. It was a set and forget because they were now used to having a set and forget medication. And so the HbA1cs went up and up and up, and they couldn't understand why now they needed more and more insulin. It was very, very, very conflicting, very difficult as health practitioners to support a client through that. really turbulent time. And like I've mentioned, some clients that really don't want to go back on it again because they don't want to have those symptoms again, except so motivated to have that opportunity to come off insulins. When you've been living with diabetes on insulin and you've been able to come off it, that's got to almost feel like you have won a marathon. And then to have to revert back, it's like, traumatic. But yeah, it did. You're right. It came back like a raging bull, and with their outcomes seemed to be far worse after coming off it. So the message behind that is, if we're going to pop them back onto it, we have to really secure supply line, which we just don't have yet. I hope that answered that question for you.
It did. Thank you, Cate.
Yes, and the mental and the emotional and the mental health well-being, and already stress putting blood pressure up, so it's that double-edged sword. I started this is what caused my trajectory in the beginning, and now I've brought it back into the equation, and really hard times. But that's where people like yourself make a massive difference. And all the people on the call, and Deep, I do remember you. I didn't recognize the surname. I thought there's another guy called Deep. This is cool. Any more questions from the room? Really happy to take any questions, comments, anything. I've learned masses, so a fabulous presentation, and thank you very much.
Thank you. Yeah, and as Rosie said, we really want to be known as the one-stop shop for diabetes, not just for people living with diabetes, but for the people caring for diabetes. We can't encourage you more to ring our helpline as a health professional, as a support worker, as a carer, as a family member. We would really like to know that if you ever had a question around diabetes, you would just call us and get that answer.
Absolutely, that's fantastic, because help is there. So just reach out, because that's what we all want to do. We want to all help each other, and that's how we help everyone out there. And that's what it is to be a health professional and care. And thank you so much, Cate. And thank you, everybody, for joining us. And we look forward to bringing our next webinar in June. And we expect that will be around new developments within cardiac rehab and cardiovascular secondary prevention, new services that are out there, and just those new ideas of how to care. Thank you so much. Thanks, Rosie. Thanks, Cate.
Thank you so much for the invite.
Thanks
very
for
much.
attending.
Take care.
Bye.
Bye.
Thank you. It was really great.
Thanks, Dorothy.
Thank you.
I thought I'd just stay on.
Helen, if you just want to stop recording now.
I will.
Yep.
Sorry, I do
No,
need to do that. No.
So if you just click more.
Yep.